Okay, great. So we're going to start. Everyone can hear me?
Yes, we can hear you, Olga.
Okay, very good. All right, so good morning. It's Tuesday, the election day. I hope that everyone is coming out to vote to advocate for the better tomorrow. We had original plans to have an actual workshop for diagnostic providers back in September, but due to some conflicts with scheduling, that event was canceled, and we were able to regroup and schedule this webinar. However, 50% of our experts are only here today because our healthcare attorney, Jennifer Kirschenbaum, and Ken Musing from Bank of America, unfortunately, are on a different training today. So me and Jackie will be covering the topic of diagnostic billing, coding, credentialing, and trying to give you some kind of solutions that might help the practice today, because diagnostic has become a very complex field, especially with the managed care demands that are changing every month almost. And they're significantly impacting the reimbursement of the practice. So even though we're going to have about 30 minutes presentation and 30 minutes questions and answer, we're both here available via email or one-on-one if that's needed to provide consultation. Let's start. So WCH Service Bureau is my company. We've been working for 17 years with healthcare providers of all specialties. Over the years, we have gained a certain reputation with diagnostic providers in areas of billing, in areas of credentialing, and education. So just so happens we have been very aware and up to date with all the updates, requirements, demands, type of audits that are taking place currently for diagnostic providers, which includes neurologists, radiologists, cardiologists, and all mobile IDTFs, and many of the portable X-ray units. So we've gained a lot of experience. We have established great communication and networking with experts in that area. And I've been working with Jackie for many years, and she has been sort of my role model in many of my solutions for the doctors that we have created, as well as Jennifer and Ken. So overall, our company for over 17 years is working with doctors to give them comfort, clarity, and security in this ever-changing, complex world. My focus of the presentation, what I do well and what I know well and my team knows well, is working with imaging providers to give them solutions in billing, in credentialing, and overall help them improve their practice. I will be covering today transparency in billing, credentialing process with insurance carriers, because lately it's becoming impossible because of the closed panels. So I will offer some solutions when it comes to diagnostic credentialing. I'll touch up on audit, but Jackie will do a more detailed, complex review and provide actual specific cases regarding common coding errors that impact reimbursement for these practices today. And I will also slightly touch upon communication with the referring sources and what type of a right relationship providers, diagnostic companies, or diagnostic providers should be having with these referral sources. And later on, we'll open up the floor for questions and answers, because we want to hear our participants. We want to hear the problems you guys are having and try to offer you help either here today, or we can do one-on-one later on. So let's start. Transparency in billing. Over the years, I have been personally working closely with CMS, OMIG, and HBMA. These are the top authorities, I would say, in the billing industry. They're the guys, or they're the companies that regulate the billing. They regulate the payments, and they have specific enforcement of rules that they want billers to follow. And I always said this, and I'm going to say it again, that billers are responsible for correct claim submissions. And I'm comfortable to say that we are in position to prevent suspicion claim submissions, meaning that knowing the policy, understanding the processes and the requirements, we're here to guard doctors. We're here to guard mobile IDTFs from submitting I would say incorrect or incomplete claims, because we have the referral form, we have the interpretation form, we have the actual order of the workflow and what was performed. We are able to review before submission if everything was properly dated in the report and it reflects the claims that are being sent out to prevent any audit. So billers are the last person of resort to have that review and to educate the doctor, educate the IDTF of the changes that need to be made, because we are aware of the policies. So OMIG and CMS are recommending to everyone, this is again for management companies or diagnostic providers who are working independently, either for global or just for the professional component, is to have closer access to the claims that are being submitted, to have a monitoring of all the receivables so they can have access and not rely on just the paper reporting, but actually see what diagnosis codes are being used, what procedure codes are being used. Are they reflected to what their ordering form was? So to have access to all of that information. In this business, trust is not only definition we can use. We have to rely and be professional. So if a company is providing a billing service, a coding service, or any type of service, there should be a transparency, there should be an access to the information so that any provider can have a look at what's actually being submitted, what's pending. Medicaid and Medicare started enforcing this rule and sending out recommendation letters to billing companies and to providers, encouraging them to have a good, strong communication between them so they can review claims, educate on what's going on, and at the same time prevent fraudulent and abusive claims of coming into the system. Billers are also in a position to educate providers. I often hear that there is a policy update. Can you please look it up? It should be the reverse. The biller should come up to the doctor or to the portable diagnostic company and inform them of the updates. As we all know, there is a thin line between fraud and abuse, and only an knowledgeable biller can provide the balance. So I always encourage to have a routine communication with the billing department. Either it's with the internal billing company or it's an outside company. Partner up, work together. You have to have access to everything that's being submitted, and you have to be educated about ongoing new changes that are coming up or things that are affecting reimbursement in the future. Once you have the communication, once there is a solidified partnership, you can look through apparent problems. You can see if your resubmission rate is high. How many times is the same claim being resubmitted? Does it become a flag at the insurance company because of the resubmission rate? Is there ups and downs in revenue? If there are ups and downs in revenue, then there's something wrong with the process. Chart review from payers has increased. Lately, I think every other day, any diagnostic provider is receiving an enormous amount of requests for random medical records. Some are targeted, some are random, but the requests are there. So again, solidifying that communication with the biller is very important for the process. We cannot let go of that, because once the diagnostic aspect is done, the test is ordered, the test is performed, all the qualification measures have been met, it goes out for billing. So that person is responsible to identify a problem before the claim is submitted and relay that problem to the client. So from today's presentation, from the billing aspect, my first recommendation is to have frequent routine communication with your billers. Credentialing. Over the last years, about 5 years, credentialing dynamics has changed greatly, especially for diagnostics. We know that some of the biggest payers, including MetroPlus, Fidelis, Affinity, our Medicaid managed plans in New York, have set barriers. They're not allowing radiologists in certain areas. They're prohibiting some of the neurologists and cardiologists as well. And they're limiting overall participation for newly graduate providers, not allowing them to come on board if they don't have hospital affiliations that are part of that HMO. So there are certain restrictions that are limiting admission into the insurance. I have to tell you that if you are dealing right now with closed panels and you have a difficulty getting in, my first recommendation as a solution for that problem is to take a 5-mile radius of within your location, look it up in the directory of the insurance company because it's a public information. If there is not a cardiologist and not a radiologist and urologist practicing within 3 to 5 mile areas, and how many of them are actually operating. I'll tell you that I was able to bring radiologists into MetroPlus and Health First simply because their internal provider directory was not updated. So there was 2 radiologists practicing according to their Health First directory, open and actively accepting patients. However, when I called the radiology several times during 1 week, no one picked up the phone. I went to see the actual physical place, it was closed. I took a picture, I wrote a letter appealing the decision Health First made on my client, and we got into Health First because they don't update their internal directories. And it's causing problem because new providers are not able to get in. This is one of the ways you can fight. Establishing communication with provider reps. They have to become your best friends. You really have to get to know them. You have to know when their birthday is and constantly talk to them because Diagnostic is expanding. We often service several counties. We all over New York State pretty much. Reps are typically the same depending on the zip code, but establishing that communication, having them come into your place of business, take a look at your report, at your technology, meet your team. They will change how they work with you, and eventually they will help you get through closed panels. Because today, if you look at MetroPlus officially has posted on their website that they're closed for radiology and podiatry. Let's look only for radiology. My connections or my relationship with these reps has been strictly professional at all times. I communicate with them, I tell them what doctors I have, what areas they're covering, what conditions they're working with as far as what type of diagnostic testing they're doing. Is it interventional radiologist or diagnostic radiologist? What hospitals they work with. And I was able to bring radiologists, for example, even last month for Staten Island location because Staten Island location is open. So there's ways you can work around even though there are certain barriers and directly working with these representatives. Authorization process has become very complex. With establishment of EviCore a couple of years ago and taking over the HMOs, the last HMO that picked up was Fidelis, has created an enormous headache for primary care physicians to order tests. It has created delay in actually administering of the tests. A couple of weeks ago, we had a primary care that called us because they wanted to complain and sue EviCore. One of the reasons was there was a female patient with an abdominal pain and the authorization was pending over 48 hours. I can only imagine that the experience for that patient, for the doctor, and eventually the patient had to go to a hospital outpatient unit to have a diagnostics done. EviCore supervisor, in response to our complaint, said, well, you should have called. Well, the doctor did call, and they told him to wait. The supervisor apologized. Overall, there was just an apology letter, but that patient actually went to the hospital. Hospital bill was much higher for Fidelis, which had to reimburse it. So there is a problem. There is an ongoing problem with authorization process. One of the reasons EviCore stepped in or was hired as a vendor for authorization is to limit any further audits. So if the services are authorized, the nurse reviews the clinical data, the reason the primary care is referring the patient for diagnostic test, there's likelihood that there will be no audit later on. It's not guaranteed, but it's sort of a prevention method from later on sending a request for medical necessity. So this is what EviCore is sort of doing right now for Fidelis. But I will tell you that I have 27 primary care providers, and about 70% of them, and it's a high number, are unhappy with EviCore. And Irina is one of the Fidelis representatives for Brooklyn. She covers several zip codes. She already received termination letters from doctors saying that they'll be switching the patients to a different HMO plan if the EviCore process would not become more smoother, because it's creating an internal problem for the patients. So I don't know how that will go, but there is a problem that is existing, and considering that Fidelis was just recently purchased by a different company, I don't know if anything will change. Most likely the whole set of procedures will stay in effect. But again, communication, working with insurance representatives will help you in a way to lift some of the complications you might have. And letting them know that you're having a problem. If your primary care provider cannot schedule a test, you have to inform the insurance company of this delay so they're aware. Regulatory updates. So OMIG exclusion list, Medicare exclusion list. I have done credentialing for groups that have hired providers with OPMC records. This information is usually never checked during an employment interview, or this information is not disclosed by the physician looking to be hired. So I would like to make a solution for everyone who is expanding and developing a practice. If they're hiring new providers, make sure that these providers are checked against the directories. Because if they're on exclusion list, either Medicare or Medicaid, there will be a significant problem getting them into the HMOs. Most likely there's a bar and they can't get in for a couple of years until they're removed from the exclusion list, re-credentialed with Medicare and Medicaid, and then they can reapply. So that's something very important to consider. Also, Medicare and Medicaid, as you're probably aware, participation status is now inevitable, because in January, if you're not participating with Medicaid, you will not be able to submit claims to managed care Medicaid plans. They will be either denied or either your contract will be terminated. So it's a big dilemma. We have a couple months to fix it. Basically, all the providers who are not part of Medicaid has to enroll into Medicaid, get a provider ID, and be part of their directory. So when the managed care can match their NPI against the Medicaid record, they're going to be in the system and the claims will be processing. So it greatly affects the referral within the network. It's something where this needs to be, you need to be informing your referring sources and checking their NPI if they're in the system. And we have a separate webinar we did for this, and we can definitely send out more information if it's needed. Revalidation is a big headache, started about 5 years ago. Some of the providers are definitely ignoring the mail that they're receiving or disregarding it somehow, or not getting it. But Medicare has established a rule. It's every 5 years you're due for revalidation, even if you're having the assignment in different groups, even if you're IDTF or physician group performing diagnostics. Every physician has to go through revalidation. They have to define the groups they have joined, and they have to submit paperwork. Again, it's done to, I guess, to update the directory and to make sure that the doctors who are in the network are providing services and actually working. So that is very important. Practice maintenance is important. If you're looking to hire radiologists today, and they have, you know, about 6 or 7 locations already on file within insurance care, I doubt they will let your locations to come in under the profile. There is a certain limit of hours, and I'll give you a quick example from MetroPlus. Only 6 locations are allowed. If there are more locations, you have to change the hours or remove the location. So there are certain insurances that have specific requirements for provider maintenance and how many locations they allow. Medicare, Medicaid are very flexible with location adding. There's a limited amount, as long as you're providing Medicare and Medicaid with the locations where the services are rendered. They can add anything from assisted living facilities to a regular practice office. This is sort of more for Jackie when she will start her slides, but reassurance through audit. How do you know that you are doing well? How do you know that you're compliant? One of the ways, of course, is to get a second opinion of your billing, and this is what we actually do. We come in, we take a specific set of charts, specific set of claims, and we match the data, including your interpretation reports, including your referring orders. And we tell you if everything is compliant, if there is areas of improvement. Yes, we're interested to have you as our client, but we're also interested to have you understand how the billing is done by a different company or an internal biller, and there is a room for improvement. If there is, we are here to help. If you don't need us, you can go back to the original billing and continue doing the way you were. But one of the ways to do it is second opinion. Just like when you go to a doctor and you have a certain condition, you want to get a second opinion of a different specialist, or the same specialist, the peer review. So getting a second opinion of your billing and your credentialing is very important. And right analysis can definitely prevent the next audit. Auditing, maintaining compliance through coding review by CPC. Jackie will touch upon that after I'm done, but basically it's the professional or certified professional coder is able to tell you if your interpretation report is by the insurance guidelines. Finally, improving communication with referring sources. I think it's an emphasis that I want to put, because talking to your primary care physicians, talking to the providers who are referring the patients for diagnostic, it's very important. Let them talk to you. Tell them how they want to change the process. Let them share with you their complications with authorizations, what can be done to improve the process. Maybe we don't need to schedule the testing before the authorization is provided. Maybe the patient can go to your clinic instead of your technicians coming to me. So let the referring doctors talk with you. They have to, now we all have to partner up, because it's becoming very complicated and mostly results in audit at this point. As a provider, tell them about your concerns for quality and process of improvement. Tell them about your technicians. Tell them about the education they're going through, the equipment you have acquired. Tell them about your protocols and how the diagnostic interpretation is done. And generally just get to know your referring sources. I can tell you that using the claims data, you can run different type of reports. You can actually tell your primary care doctors that these patients need to be called back for a follow-up test. This particular female is at the age of 34. She never had a breast exam. So you would schedule her. Sometimes primary care physicians are they don't have time to have access to that information. They don't know how to look. Claims generation, generating a claim and building up a database gives you a good analytic tool to have, and it's very, very important to use that information. So again, speaking with your biller, including that in that communication with the primary referral source, and building up a strong relationship. I'm gonna pass Jackie to you now, and I'm switching my presentation.
Okay, thank you, Olga. I want to thank Olga for hosting this webinar for today, for the opportunity to present, and most importantly, for that in-depth, valuable information, particularly regarding the transparency in billing and her professionalism, not just with billing, but also with credentialing. So I was happy to hear all that valuable information. Now we're going to switch gears a little bit, and we're going to talk a little bit more about the documentation that's required by the physicians. So most of my work is done from the auditing perspective, not so much with the claims information, but with what the physician actually puts in the record to make sure that the documentation is going to support the services that they are providing. So the first thing that we want to do, we're going to talk a little bit about our valid orders, which is the key, because without that, for any diagnostic test that's being done, you simply don't have a billable service. The next is medical necessity, your documentation requirements. We'll talk a little bit about the NCCI edits and the local coverage determinations, some modifiers, and where you can go to learn more about it. So an order is really that communication that you're going to get from that treating provider. The doctor who is actually taking care of the patient needs to make a request for some sort of a diagnostic test if it's being sent out to a mobile company or to a diagnostic facility, or even within their own practice. So if they have an ultrasound machine or an X-ray equipment, even though they own the equipment, they need to put that order in their medical record. And it's usually a written document. It needs to be signed by the requesting physician, and it has to be clearly legible, the name of the physician. You can also do it by telephone call. However, that is the exception. It's not the rule. So sometimes patients will present to the testing facility. They don't have that order with them, or they forgot that script that the provider wrote. And in that case, you're not going to turn the patient away and say, come back next week or tomorrow when you have the order. You can actually take the information from the patient, enlist why the patient is there in the patient's own words, and that needs to be followed with a telephone call to that treating physician's office and documented. And now what's really nice is we have a lot of electronic referrals, which actually take away that illegible signature, takes away a lot of confusion from the order. And this is basically what I said. If you're going to do a telephone order, both the requesting physician and the testing facility has to document that in their notes. And, clearly, you're going to see more and more of the companies, the insurance companies, when they're auditing these diagnostic facilities, they are going to go back to that treating physician and make sure that somewhere in that treating physician's medical record for that patient is supporting documentation for that order. So they want to see that the patient really did come to the doctor complaining of abdominal pain, if they're being sent for an abdominal sonogram, or that they did have some issues that required them to have an echocardiograph. So what constitutes a valid order? For that order to be valid, at the minimum, it has to have the patient's name, the test requested, the clinical indication for the test. Why is the patient having this test? A legible name, signature, and date, and signature stamps alone by themselves are not acceptable. And that's because anybody at any office can grab one of those signature stamps and just start writing up a bunch of orders. And in those cases, when the carrier does go back to that treating physician, normally we don't find any requests in those patient notes. So signature stamps are not acceptable. The Medicare Claims Processing Manual states that the ordering physician must provide the diagnostic information at the time the study is ordered. So just what I said, when that patient presents, they must have that order. If they don't, and that order is being communicated by telephone, which is the exception, not the rule, you should make sure that you're calling the facility and documenting that information. Okay, so here we have an example. The patient's referred to the radiologist for abdominal ultrasound. The requesting physician doesn't give the reason for the referral and is unavailable at the time of the study. Sometimes you'll get that order and it will just say either rule out or it just won't have an indication. In those cases, you must call the facility and get a valid diagnosis, because rule outs are not valid diagnoses, or you must find out what the indication is. And that clearly has to be documented in the patient's record. There needs to be that same indication documented in the report. So if the patient is coming for abdominal pain, and that's what's on the order, when that radiologist starts to read that report, that indication must be in the report. You cannot say a generic statement like evaluate pathology and source of complaint. Specifically, what is the reason that the patient is there? And any order that doesn't have an indication is not valid. So here we can see an example. The patient was coming for an ultrasound of the thyroid. We have no indication. So if you don't have an indication on your order and you have no indication on your radiology report, you simply do not have a valid reason to do this test, and the carrier will come and take the money back. The next thing we find is clone documentation. And the definition on this slide comes right out of the Medicare Internet-only manual. And when there's clone documentation, that gets considered to be a misrepresentation of the medical necessity. And if we have no medical necessity, you just don't have a billable service. They will recoup all of that money. So in this case, here you see that indication. It's just evaluate pathology and source of complaint. We really don't have a valid indication. This is what we saw, and all of this particular provider's tests as their indication. There must be a clinically appropriate evaluation of the patient prior to any test being ordered. So this is where Medicare will actually go back, and when any provider is being ordered for radiology, they're going to pull a couple of these orders, and they're going to go back to the requesting provider, and they're going to see if there is the same information in that patient's medical record. So they do go back and they check. And then in order to bill any CPT code, the service has to be documented to the full description of that particular code. Most often what we find is when providers are billing that complete ultrasound of the abdomen, they start to bill the kidneys as well. Now here on this slide, you see the difference between a complete ultrasound exam of the urinary tract, and also this can be, if there's just clinical history suggesting urinary tract pathology, you can also bill that complete 76770. When it comes to your complete abdominal ultrasound, it includes the kidneys. So you would not report both the ultrasound of the abdomen and the ultrasound of the kidneys. So here we see the patient is coming for an abdominal ultrasound. We really don't have a valid indication. We see that they document the liver, they document the spleen, we have the gallbladder, and also we have the kidneys. And the kidneys are included in the abdominal sonogram. But what was billed for this particular patient was a comprehensive or a complete abdominal, as well as a comprehensive or complete renal. So you have to watch what's bundled. Timeliness is another issue that they look for. And it has to be documented, the note has to be documented at the outset. And what happens here that we find with these records is if someone is coming today for a diagnostic test and that report does not get sent back to that requesting provider for a month, how valid is that medical necessity for the test? So these are things that they look for. Here you can see on this example that the order was dated for April 14th. The report date was dated September 19th, and the approval date was September 20th, and we have our documentation on September 19th. So the patient actually came for the test in April, and this test did not get sent back to that requesting provider until September. So when the carriers see things like this, there's really no medical necessity for this if the patient has to wait a month before that treating physician will get their report back. So you can see that this was electronically signed on September 20th. It's not enough to link the correct procedure code to a payable diagnosis code. That diagnosis or clinical sign or symptom must be present. So a lot of times what providers do is they will go to the local coverage determination and say, oh, look, these 25 diagnosis codes support this service. Let's just pick one of them to get the claim paid. And actually, when they go back and they look in the patient's record, that patient never had that indication. Rule out, as I mentioned earlier, is also not a valid reason for the test. There are no rule out codes in the ICD-10 manual. Rule out codes are only good in the inpatient setting because they can use it as a working diagnosis, but in the outpatient setting, they are not valid. In cases where the provider is writing as an indication to rule out a particular condition, to rule out pneumonia if they're being sent for a chest x-ray, in those cases, you need the sign or symptom, which might be the fever, the cold, the cough. But again, if that script comes in with a rule out, you must contact that treating provider and get what that sign or symptom is. And this comes out of the ICD-10 manual. Okay, training and expertise is also important because only certain providers can do certain tests. And this also goes in with your ultrasound techs and your echo techs. There are certain technicians who are credentialed to do certain techs. And the reason, or the way that the carriers find this out in an audit situation is they are looking to see on that image the name of the tech who provided the service. And this way they can go back and check to see if an echo is being done, if that particular tech has the credential to do the echo, and so on and so forth. Some of the PACS systems, I know Fuji, they don't print on the image, but they have a sign-in screen that gets locked. So you're able to print that out as proof in case of an audit situation. Also, with certain tests like VNG testing, it's the type of the specialist, the provider who can read that particular study needs to meet the requirements of the training and the expertise. With your vascular studies, your VNGs, your nerve conductions, your echoes, all of these types of tests, the equipment now is so sophisticated that it prints out 10 and 12 pages sometimes of the graphs, as well as it will give you a written report at the end. It's really important to know that that printout on the report does not constitute a written report. It's what the machine is concluding. The physician needs to be able to put in their EHR, their observations, their written report, their determination, and most importantly, how that provider is going to use those test results in treating the patient. That's one of the major issues with the Medicare audits and all the other carriers. Doing that diagnostic test has to result in some sort of an assessment from that provider on how they're going to use these test results to treat that patient. And if the test comes back that it's negative, what is their next method in treating that patient? Are they moving on to different tests? Are they going to try something different? So that needs to come from the conclusions from the physician, not the printout that comes from the studies. Most of this information is readily available in local coverage determinations or LCDs that are found right on Medicare's website, and the link is down at the bottom. Just like, Olga mentioned, a lot of the rules and regs change frequently. These also change frequently and should be checked routinely for updates and revisions. The local coverage determination will give you the valid indications on why you can do these tests, what the limitations are, how frequently can these tests be provided, what are the requirements, who are the qualified professionals, what constitutes medical necessity, and also what is that required documentation that needs to be in the record. When you click on that link, this is the slide that you'll see, or the screen that comes up. You can search your local coverage determination by the ID number. So once you get your LCD, you can just key it in here if you're going back to do some follow-up. Notice you can search by either national, local, or national and local coverage documents. The difference between the two is this is at the local level, which is your Medicare administrator contractor. For most people in our geographic area, it's going to be national government services. If there is no LCD, you can always get something from a national coverage determination. You then need to check your geographic area. This will come down for New York. New York is also broken up into downstate to Queens, so you really need to choose carefully. If you know your CPT code, you key it in here. If you don't and you just wanted to put in echocardiograph, you could use a keyword and then that will come up for you, your local coverage determination. Within the LCD is where you can search the covered diagnosis codes. Again, the patient must actually have that condition. You can't just choose one that's payable. Your National Correct Coding Initiative, this is where billing companies are so valuable because they invest in their claim systems to have claim scrubbers, where this information is built into their system and will stop these claims from going out that are bundled together. You can also get this information on the link over here, the NCCI edits, and what this does, it will tell you groups of codes that are bundled together. Like I said, that complete abdominal sonogram and the renal sonogram are both bundled together. These NCCI edits will change quarterly, so it's really important to stay on top of this. And this is what it looks like when it comes through the claim editor. And some of these actually come up and they will say that you cannot use a modifier to override the relationship. And what Olga was saying before, is so important. Having that transparency, having that communication between the billing company and the physician. A good billing company will pick up on things like this when it goes through their claims scrubber and reach out to that physician's office and say, you know, Dr. Smith, we're getting this billing information coming from your facility. It's going against the NCCI edits. They'll take the time to explain it, educate the provider. This way, it avoids this on a go-forward basis, which will avoid you from being audited. Autonomic function testing, a lot of the providers call this the pseudo scans. Let me tell you, this is highly audited, and also the indications for this, or the diagnoses that allow you to do this test, are very, very limited. And look at what it is on the second bullet for the documentation requirements. The medical record documentation maintained by the performing provider. This is now not the treating provider, but the provider who's performing the test has to support that medical necessity, as well as the test reports and the interpretation. They have to have supporting documentation that shows medical, reasonable, and necessary indications that are in the LCD. So that's an additional burden that's put on that testing provider for these types of tests. And this is what the LCD would look like. When you search the LCD for this, notice it comes up with your LCD number. So you can go online and get all of this information. So the providers will know in advance before they start doing tests that either they're not going to get paid for or will have to pay money back. Also, it says that the providers who perform these tests on an unusually high portion of their patients or at frequencies that exceed once per year might be subject to medical review. Again, this is where your billing company, if they are, very professional, will pick this up, as Olga mentioned, when they start to run the data and they start to run the reports. They can pick up this information and bring it back to their clients. Also, this type of test requires tilt tables. Okay, so any provider who does not have the tilt table for this test could be subject to medical review as well. The carotid Doppler, I get this all the time. Dizziness alone is not enough to perform this particular test, okay? And it says right here in the LCD that studies may not be considered medically necessary if performed for these following signs and symptoms, and here they're listed. So educating the providers as to what is required is really key in getting these tests paid and keeping the money. The nerve conduction test. This is another high area. When a provider chooses to perform just an NCS, when performed alone, it's usually considered not medically necessary. And again, these tests, most often what we find is missing is how these test results are going to be utilized in the treating of the patient. These are some links where you can go to learn more about it. I do strongly advise everybody to go to the LCD site and pull down those local coverage determinations for any testing that you are providing. And I'm going to turn it back over to Olga now. Thank you for listening, for some Q&A.
Thank you, Jackie, so much. So we're open now to questions from our participants. We'll give a couple more minutes for people to, you can actually write if that's comfortable for you in the GoToMeeting feature, or just voice the questions here.
I actually have a question. Can you hear me?
Yes, we can. What is your name?
This is Alicia Adams from Mill Basin Radiology.
Hi, Alicia.
Hello. My question is, and I've been going through this at least once a week between our billing. We have an external billing company, and at least one of our companies regarding getting the referring doctor's chart notes, especially if some of the texts seem to be taking shortcuts with the clinical history and or writing it illegibly, and we have to try to decipher it. The complaint that the pushback that I'm getting is that they're saying they don't want to ruin the good relationships they have with the referring doctors by, they claim, bothering the referring doctors by asking them for the notes. So I've sent out so many policy emails. I've been sending them out for about 3 years now. The same type of emails with constant updates, and it comes back down to us needing the official documentation. How do I get them to understand how important it is?
Can I respond?
Sure.
Yeah, it comes down to getting that valid order in first and foremost. So, if that order is not, if it's fully complete and it's clear and it's legible, and that's why more and more of these companies are moving towards the electronic, you're in a better place. Because what will happen is when, and I don't know, some carriers put providers on prepay review, some of them are actually being audited. And when they seem to feel that some of these orders are suspicious, whether it comes down to frequency or whether the orders are just not clear and legible, it's going to become the burden upon that facility to get that information from the referring providers. So one way to avoid that is to make sure that your referring providers are educated to give you a clear, legible, and valid order. But getting it after the fact, that's another issue. But Medicaid and Medicare both have on their website that it sometimes will become the burden of the treating provider to get that information. So, perhaps using that and saying, listen, we're required to do this would be helpful. Olga, your comments?
I would just, everything Jackie said is exactly how it should be done. I could only add one component, is that if you have a certain amount of these doctors, and this is now a pattern in these offices, I would recommend doing like a short lunch or some kind of session where you'll invite them to your place of business or go out to a small place where you can eat and sort of discuss the importance of this fact, and they're at risk of actually losing diagnostic services at this facility, because you need the notes. It cannot be without them. And Abico is one of the proofs that you have to submit notes.
Yes, definitely. Okay, no, that is a good idea. I have to run it by our supervisor, because that would take some planning. But I think that maybe a face-to-face meeting would help. I mean, they seem to not read my emails, or they read portions of it. So I think it would help. Because
for them, it's not a concern. They're getting their rent or they're getting the services done, but overall, this is changing. You're not going to get paid.
Yeah, and face-to-face is always better when you have that personal touch to it. And, you do it with the praise sandwich. You're thanking them for the referrals, and you're telling them what you really need. But the goal is to try to get that valid order from the get-go. Are most of them using the electronic, or they're still doing paper?
Some are using electronic, some using paper. But even with the electronics, I mean, some of them are sending electronic, like technician's notes sheets. And it helps to have it printed, that we're not having to decipher the text handwriting either. But then we can't, they'll have some of the techs make up their own acronyms for symptoms, and we have to then chase after the tech and find out what they really meant. I wish I could say it was the exception, but it's happening more and more often. We'll look at it and say, oh, good, it's printed. And then we really look at it and we're like, what is that? So
it's kind of cryptic. Well, you can ask them to give you their acronym list. And you really need to keep that on file, too, because if a carrier comes in and, they don't know what that acronym means, they'll deny the claim.
We'll have to have we'll have to have documentation that, the email can only go so far. If there's the specific one this company's using all the time, then Okay, thank you so much.
Thank you, Alicia.
You're welcome.
Anyone else? Okay, if someone's still connecting or bringing up the question, we want to say that we do have CEU credits available, and if anyone is interested to obtain the CEU certificate for this class, please email to me or to Daria, the organizer, and we'll send you by email the certificate for CEU credits. If there's no more questions, again, our emails are available. We'll send up a follow-up email to everyone with our contacts. And if there's no more questions, we can end the session. And I thank everyone for joining. Jackie, thank you so much for taking time of your busy schedule. I know that we brought something valuable to everyone who listened, and we're here as experts to help.
Thank you, everybody. Have a wonderful day. And thank you, Olga, for putting this session together and for allowing me to participate.
Thank you. Have a great day, everyone. Bye-bye.